Good evening, everyone. Myself, Dr. Debarun Chaudhary from Sangangaram Hospital. Today, I shall be presenting a case of a 43-year-old married female teacher by profession, resident of Hisar, Haryana, admitted.
Your voice is breaking.
Sir, am I audible?
Yeah. Now it is okay.
Okay, sir. So today I'm presenting a case of a 43-year-old married woman, teacher by profession, resident of Hisar, Haryana, admitted on 6th of December 2022 and examined by me on 10th of December 2022. History provided by patient herself seems reliable, and she has presented to us with chief complaints of cough for 7 days and blood-tinged sputum 2 episodes in 1 day. History begins from November 2018 when patient noticed discharge from both her ears. Initially it was mucoid, later it became mucopurulent, scant in amount, without any characteristic odor, and it was associated with dull aching pain. She also complained of reduced hearing from both the ears in the form of reduced perception of the intensity of sound but retained speech discrimination. There was no tinnitus of her face to the right side, and she was unable to close her left eyelid completely. She consulted an ENT surgeon who told her that she has infection of both the ears, and it has also involved a nerve of the left side of her face. She was admitted in a hospital and was started on IV antibiotic and oral steroid. Her symptoms gradually improved. Her blood tests were normal. She was discharged after 5 days on oral antibiotic and oral steroid on tapering dose. However, deviation of face was still persistent and after discharge, there was increase in the pain in her left ear. She also, which was anesthesia in December 2018.
Dr. Debaran, sorry to interrupt. We kind of lost your voice in between.
Okay, sir. So am I audible?
You're audible. I think your network's kind of weak. It's going in and out intermittently.
Sorry, sir.
Can you start off from she was admitted, she got some antibiotics and then was discharged? What happened after that?
Okay, sir. Okay, sir. She was discharged after 5 days of hospitalization on oral antibiotic and oral steroid on tapering dose. However, deviation of face was still persistent, and about a week after discharge, there was pain in her left ear. She also developed high-grade intermittent fever without chills or rigor, and it was relieved with oral antipyretic. There was no headache, loss of consciousness, or seizure. MRI brain was done, which was normal. She underwent ear surgery under general anesthesia in December 2018. On postoperative day 2, she developed productive cough, which was mucoid, about half a cup in a day, without any characteristic color or odor, without any diurnal or postural variation. She had 2 episodes of blood-sweat sputum, around 50 to 100 ml in amount, without any history of shortness of breath or any oxygen requirement. There was no history of burning micturition, loose motions, weight loss, or anorexia. Chest X-ray was done, followed by CT of thorax, and she was told that there was no infection or bleeding in the lungs. Her hemoglobin at that time was normal, and renal function tests were also normal. She does not remember being told that there was any abnormality in her urine examination. A lung biopsy was done in January 2019, and she also tested positive for ANCA. There was no history of any any nasal discharge, epistaxis, or deformation or joint pain, no history of hematuria, frothing of urine, reduced urine output, or swelling of legs or face. After written and informed consent, injection cyclophosphamide and IV steroid was started. She received IV steroid for 3 days, followed by oral steroid at 60 milligram per day, which was gradually tapered. Injection cyclophosphamide was initially given at 2 weeks interval, followed by 3 weeks interval. During the course of her treatment, her serum creatinine increased to 1.8 milligram per deciliter, and she was told that she was leaking protein and blood in her urine. There was no history of fever, hematuria, proteinuria, or oliguria. She underwent kidney biopsy in January 2019, which revealed features of the same ANCA-associated disease. Dose of
No,
oral steroid.
that's 1 minute, 1 minute.
Yes,
Patient
sir.
says that revealed feature of the ANCA-associated
Yes, sir.
disease.
Yes, sir. She was told that it was similar in nature to her lung disease, sir. It was the ANCA related disease, sir. There was no nothing else. It was ANCA related disease.
And when the treatment started, after kidney biopsy or before kidney biopsy?
The treatment was started before kidney biopsy, and she had already received 2 doses of injection cyclophosphamide, sir. After that, her creatinine actually started to rise.
And one more question. You left
Yes.
the story, the HRCT was normal, there was no lesion, there was no drop in HB. Then why did she get a lung biopsy? And why did somebody test for ANCA?
She could not specify actually what type of lesions were there in the lung. She was just told that there was no infection or any bleeding, and there was necessity for a lung biopsy. She could not actually specify what type of lesions were there in the lungs.
Okay, because the story kind of took a break and then again started. What year are you, Dr. Devaran?
Sorry, sir.
What year of training are you?
Sir, I'm in second year right now.
Second year. Okay.
Yes.
Yeah, please
No,
continue.
so that because if the CT scan is normal, why would anybody do a lung biopsy? The point is that so there must be some abnormality in the CT scan
Yes,
plus symptomatic,
yes, sir.
and probably I don't know. The first step usually is always to go for the bronchoalveolar lavage and thing. Unless you find some specific lesion in the lung,
Yes, sir.
it's difficult to. Well, where would you do biopsy? It's invasive, and there are high chances of bleeding in lung biopsy.
Yes, sir.
So there must be something. You have missed something in between.
I asked her, sir, but she could not actually specify that what type of lesion was there, and she just
No,
said
but
that they asked to get a biopsy because there was
normal,
something in the lung.
normal CT scan, nobody is going to do lung biopsy.
Yes, sir.
Okay.
Do you want to finish your history of present illness and then we'll talk about a few things?
Okay, sir. So, she underwent kidney biopsy in January 2019, which revealed features of the same ANCA-associated disease. And dose of oral steroid was increased to 80 milligrams per day. Injection cyclophosphamide was continued at regular intervals for a total of 10 doses, and steroid was gradually tapered. Her serum creatinine also started declining, and it was normal after the 10 dose. It was around 0.7 to 0.8 milligram per deciliter. Repeat urine examination was also normal, and she was started on maintenance therapy with injection rituximab 500 milligram. A total of 5 doses were given. Initial 2 doses 2 weeks apart, and the last 3 doses at 6-month interval. Last dose was administered in July 2021. She was found to have hyperglycemia, and she was told that it was probably steroid related. So she was taken off steroid in August 2021. In October 2021, she again had an episode of hemoptysis. There was no history of fever, anorexia, weight loss, hematuria, or proteinuria. Her blood tests were normal, and urine examination was also normal. CT thorax was done again, and she was told that she does not have any infection, and it was probably related to her ANCA disease. She was given 3 days of IV steroid followed by oral steroid taper. ANCA test was repeated, which was negative. She was discharged on oral steroid at a dose of 60 milligram per day. Now, after almost a year, she has presented with productive cough of 7 days duration, which is mucoid in nature, around 100 to 150 ml per day, without any characteristic color or odor. She also had 2 episodes of blood-tinged sputum in 1 day. There is no history of fever, shortness of breath, or chest pain. Her hemoglobin was 11 gram per deciliter, creatinine 0.8 milligram per deciliter, and urine examination was normal. ANCA test was repeated, and this time she tested positive. CT thorax was also done, which did not reveal any active infection. Sputum analysis was done, which was normal. Bronchoscopy was done, which was normal. And she was given injection rituximab 500 milligrams along with 3 days of IV steroid followed by oral steroid at 30 milligram per day. On direct questioning, she also complained of joint pain involving both knee and ankle joints bilaterally, no history of redness or swelling or any deformity or restriction of movement of the joints. There is no history of rash, ear discharge, redness or watering from the eyes, oral ulcers, or hoarseness of voice. So this is my history of present illness.
Completely
That's
negative
fine.
history and whatever.
Dr. Devran, one
Yes.
small point, and just one general teaching point for all other students also.
Yes,
See,
sir.
you are, almost going to be a nephrologist in 1 year. When you are taking your history and presenting your case, you have taken a very exhaustive history, very good, part there. But then you again have to process the information and present the information to the person listening. See, we don't know anything about this case. So
Okay, sir.
your presentation should be such that you are painting a picture, like you're doing a good chronological presentation, but at the same time, see, you're presenting the case to a nephrologist. You mentioned she had a biopsy in January 2019, and
Yes,
all
sir.
you said was the findings are consistent with ANCA.
Yes, sir.
But as a nephrologist, see, I would like to know more. What really was the finding in the kidney biopsy in the first go? Because she's
Yes, sir.
completed a course of induction, got some maintenance, and now she's kind of relapsed. We
Yes, sir.
can talk about treatment all day, but like again, in your history part, you should be very succinct about, what was the nephrology part that time.
Okay,
What
sir.
did the biopsy show? Were there any crescents? What was the chronicity? What was the creatinine? You mentioned 1.8 when the biopsy was done.
Yes, sir.
And then again, the biopsy findings. So I would have included it there, number one.
Okay,
Number
sir.
two, Dr. Sham already mentioned, you kind of ran into the lung biopsy part. So you
Yes, sir.
should paint a picture, when we can kind of just listen to the story and picturize.
Okay, sir.
Also, I don't know if it's coming forward, like, do you have a pertinent negative history about her other details? For example, was she taking any drugs? Did she have any other comorbidities?
Yes.
Are you going to
So she
present
was
that?
not. No, sir. She had been previously non-diabetic and normotensive, but after starting steroids in around July 21, she was on routine evaluation. She was found to have hyperglycemia, and she was told that she was probably having steroid-induced diabetes, sir. And it was
Okay.
then she was started on insulin, sir.
Why did I ask the question? What medications was she taking before all this started in 2019?
So, there are some drugs, sir, which can cause ANCA-associated and ANCA-related vasculitis. And so she was not taking any such because she did not have any comorbidities prior to that. So she was not on any regular medications. Sir.
Okay. If you go to the list of drugs that are associated with drug-induced vasculitis, the list is probably,
Yes, sir.
easily 30, 40 medicines.
Yes, sir.
Name 4 broad categories or give me examples of 4 or 5 drugs that are most commonly implicated in drug-induced vasculitis.
So most common will be hydralazine. It is the most commonly implicated drug. Then there are thyroid drugs for hyperthyroidism like propylthiouracil, carmimazole, methimazole, then minocycline, and even cocaine, which has been adulterated with levamisole. These can cause drug-induced vasculitis.
Sure. So yeah, good point there. And then the TNF inhibitors, infliximab, etanercept, they are also commonly indicated, and the other common things are isoniazid and rifampicin, the common ATT drugs.
Yes.
So I think a pertinent negative drug history is also important here because whenever you're talking about ANCA, this
Okay, sir.
is something you should think.
Okay, sir.
All right.
So tell me this, is the patient was knew about the biopsy finding of this patient, or he was just she was just no, that is ANCA associated?
Sir, she could not tell me she could not give a description of the biopsies.
Yeah, so it is difficult on the history
Yes,
to find out whether there was the biopsy change unless you have seen biopsy yourself.
yes, sir.
You are not able to tell. So I think the patient would not be able to tell the details of the biopsy finding. Patient will only tell what he knows.
Yes, sir.
Yeah. Okay, personal history. So complete the history.
Okay,
Any is significant in the history, family history.
sir, in past history, she was diagnosed to have pulmonary tuberculosis, sir, which was sputum negative, radiologically diagnosed in 2004, and she had taken ATT for 6 months. She was also diagnosed to have hypothyroidism in November 2018. That is when her symptoms started, and she has been on tablet levothyroxine 50 micrograms since then. And in the personal history, sir, nothing significant. In the obstetric history, sir, she had 3 abortions, sir. It was medical termination of pregnancy at first month, and there was no surgical, no dilatation in curettage. All were medically managed all at the first month, sir. And in the family history, sir, her father died at around 70 years, probably, sir, due to a blood malignancy, and mother died at 62 years due to cardiovascular cause. No other family member has any similar complaints.
Okay, so you have completed your history. So what is your diagnosis and differential diagnosis on basis of history?
Sir, my provisional diagnosis will be systemic vasculitis, probably uh, systemic vasculitis due to ANCA-associated vasculitis, sir, probably PR3 ANCA, uh, uh, with extrarenal involvement in the form of chronic suppurative otitis media and lung involvement, status post lung biopsy, status post induction with 10 doses of injection cyclophosphamide and maintenance therapy with 5 doses of injection rituximab with 2 relapses, and with past history of pulmonary tuberculosis treated with ATT, hypothyroidism, and steroid-induced diabetes mellitus.
So this is, you are saying GPA.
Yes, sir, GP.
So it is means from the, so what is the classification of vasculitis? How do you classify and what are the features of various vasculitis?
Sir, vasculitis are classified based on the 2012 International Chapel Hill Consensus Conference, where they have classified vasculitis based on the predominant vessel size involved. So there can be large vessel vasculitis, medium vessel, and small vessel. There can be single organ involvement or vasculitis due to probable etiology. So ANCA-associated vasculitis, this comes under small vessel vasculitis. Small vessel vasculitis, again, there are of 2 types. One is post-immune and one is immune complex mediated. So ANCA-associated, it comes under the post-immune category of small vessel vasculitis.
Dr. Devaran, one question. Suppose
Yes.
you were there in 2019
Yes,
and
sir.
we give you a one-liner 43-year-old coming in with,
Yes, sir.
hemoptysis and hematuria.
Yes, sir.
Then, like sir was asking, what are your differential diagnosis there? This is a bit, 2022, we are in the age of a lot of data. The
Yes,
case
sir.
was kind of given to you already. This was ANCA-associated vasculitis. But had you seen her in 2019 first,
Yes,
so
sir.
what all would be your differentials? What would you think then, and what tests would you like to run?
Sir, definitely ANCA-associated vasculitis would be on my mind, and then apart from that, sir, SLE would be my second differential, and
Okay.
and then I would also like to keep, sir, anti-GBM, although anti-GBM disease, although the age group does not fit, but there's a possibility of anti-GBM because there was both pulmonary and renal involvement. So these 3 will be my top three differentials.
Okay, so rightly said, you think about the pulmonary renal syndromes, ANCA, anti-GBM, and then any other concurrent GN, you can have ANCA plus anti-GBM also.
Anti-GBM. Yes,
You
sir.
mentioned lupus already.
Yes, sir.
Rarely, you could have some other GN, even IgA, something like that.
IgA
But
was.
outside that, we've talked about drugs. The
Yes, sir.
other thing is common thing first, infection associated, maybe it's an LRTI and also then consider malignancy. So you
Mm.
always have to keep a broad differential
Okay, sir.
and then approach the case. This was again like, you were already given the answers here. So ANCA, what are the two patterns you clinically see?
Sir, one is cytoplasmic and one is perinuclears.
Which one is associated with the MPO and PR3s? Do you know?
Sir, PR3 is associated with CNCA, sir,
Mm-hmm.
and MPO is associated with PNCA.
Okay, perfect. So basically, while you are evaluating the patient, what all tests would you be sending? Like you have your differentials on your mind now. What all tests would you order?
Sir, I'd like to order, sir, ANA,
Mm-hmm.
Why?
anti-DS.
Why
Sir,
anti-TSDNA now? Means in this patient,
sir,
it's
if I'm thinking
diagnosed.
I was asking him in general, sir,
in
like
general,
general approach to pulmonary renal syndrome.
Acha.
sir, ANA, anti-DS DNA, MPO, and anti-MPO antibodies, anti-PR3 antibodies, then anti-GBM antibodies. Then, sir, I'd also like to do the complement levels.
Mm-hmm. And then HRCT of chest to review the lung
HRC.
picture, and then as indicated, kidney biopsy if the patient is stable.
Yes, sir.
Would you start your treatment? Suppose you're not able to do your biopsy, the patient is ventilated, not hemodynamically stable.
Yes, sir.
What conditions would you like to start an empirical treatment?
Sir, if the sir clinical picture is compatible with a small vessel vasculitis, and if the MPO or PR3 antibody ELISA tests are positive, then I can straight away start the treatment without waiting for the biopsy.
Okay. How are you going to start treatment in such a patient?
Sir, start with an induction phase, sir. So induction phase, if the renal involvement is, I mean, the creatinine level is less than 4, then we can either choose between cyclophosphamide or rituximab. However, with creatinine, if the creatinine is more than 4, we have to start with cyclophosphamide inductions.
Okay. What other factors do you consider while choosing your induction agent?
Sir, it has been seen that for relapsing disease or with PR3 ANCA positivity, then in children, adolescents, or the women of childbearing age, uh, or very elderly patients, rituximab will be preferred, sir, over cyclophosphamide.
Okay. Dr. Sham, how do you drive this further? Induction, maintenance, discussion on trials?
Yeah. So means you have asked your question. Can I now?
Yeah, yes, sir, please.
So what is difference between this PNK and PNK vasculitis?
Sir, Priyanka, the immunofluorescence pattern is located around the perinuclear pattern, sir. And in CRK, it is
The overall clinical features and their outcomes and all that.
outcomes. Okay, okay, sir. So, sir, CNCA, that is PR3 ANCA, sir, this generally occurs in the age group of around 50 to 70 years, sir. And the MPO ANCA, this generally occurs around a decade later, around 60 to 80 years of age. Then, so there is
50 to 80 does not mean so it's more common in elderly. That's okay, but then if there is somebody 60-year-old, she is only 40 years old.
40 years old, yes, sir.
So there is a wide
Okay.
variation. More
Yes, sir.
commonly, if it comes in the elderly, then you will think of a vasculitis as a first diagnosis. Comes in the early age, and it will be think as a immune complex or the SLE associated diseases. So that 50 to 70 or 60 to 80 does not matter. You tell me, how do you differentiate
Okay,
what
sir.
is the difference in the clinical symptoms or clinical features and treatment or the outcome of these two conditions? How is it different?
Okay, sir. So, sir, in PR3 ANCA, the upper respiratory tract involvement is more common, sir, compared to MPO ANCA. There can be sir, destructive lesions along with destruction of the nasal cartilage. And PR3 ANCA, sir, lung involvement is in the form of nodules and cavities, whereas MPO ANCA is more in the form of fibrosis. And
Then can you differentiate in the lung lesion? See, lung lesion is a vasculitis process.
yes, sir.
See, so I see. So both upper respiratory tract or ear involvement, especially
Yes,
the ear involvement, is common. That's how you different.
yes,
Yeah.
sir. But yes, sir.
So polyangina,
PR3.
this MPONCA, this you have usually lower respiratory tract involvement and the kidney involvement. In this, you
Yes,
have upper respiratory tract and ear involvement.
yes, sir.
It's the characteristic. That's how you usually differentiate. That is the clinically you can say that this is likely to be common, and
Yes,
sometimes
sir.
there can be overlap in the symptoms also.
Yes, sir.
But in lung lesion, ultimately the pathology is same.
Yes,
So there would be active inflammation or cavities or nodule, and then later on there would be fibrosis or
sir.
whatever that later on once the disease is controlled or uncontrolled and chronicity and all that. But then that is a chronic thing that will happen to any of these situations. So basically, ear involvement or upper
Okay.
respiratory
Upper
is
respiratory. Yes, sir.
more common. And what else?
And sir, in renal involvement, sir, MPO and CA, it is IFTA is more common, sir. It is more of chronic changes in MPO and CA compared to PR3 and CA. So the prognosis is poorer.
Because that will depend on the time of the presentation, isn't it?
Yes,
When the patient, when are you diagnosing the patient?
okay. Yes, sir.
Of these patients, they have rapidly progressive renal failure sort of course. Some of these patients have the upper respiratory tract or lower respiratory tract symptoms and later kidney involvement.
Yes, sir.
It will depend what type means chronicity will depend if you diagnosis when you diagnose the patient, is it given as a differential that's a chronic changes or acute? The more rapid
If
is sometimes in the PNCA, means the MPNCA. So
MPO and yes,
that is one of the characteristic. But then there is a wide, because both are the small vessel vasculitis
yes,
and centric transformation is very common.
yes,
So both can present at RPGN,
yes, sir.
and the difference in the vasculitis is usually of varying severity. In some day it can be from the active lesions, chronic lesion. That's how you differentiate with anti-GBM disease.
Yes, sir.
So that is the depends on the presentation. So many patients they don't come to us; they go to the rheumatologist and they have some other symptom, and then they are diagnosed with vasculitis. So only patient with rapidly progressive renal failure or some kidney involvement they come to us.
Okay,
So what other difference do you have between these two?
sir. Um, relapse rates are higher in PRC and refractory to treatment, and it is more responsive to rituximab compared to cyclophosphamide.
Yeah, so that is the one of the differential feature. The relapse rate is higher
Higher.
in PR3 ANCA, and that's why you need to give prolonged treatment in patient who have PR3 ANCA associated vasculitis as compared to MPO ANCA. So that is that is. So is there any significance of ANCA? The patient is relapsing. Do you die relapse by the ANCA?
No, sir. Actually, there is not much evidence that ANCA titers correlate with relapse or the severity. However, there is a modest evidence. As per KDIGO, there is modest evidence that persistence of ANCA or reappearance of ANCA after initial disappearance, this might suggest a relapse. However, the evidence is not very robust.
So how will you diagnose if the patient has actually this patient was on the immunosuppressant, she was on maintenance rituximab.
Yes,
I
sir.
think giving rituximab, she did not stop any time or she discontinued it.
No, sir. She
She did not.
received 5 doses, sir. She completed
No,
the
but
course.
was on the maintenance treatment or she was at any time did she miss a dose of
No, sir.
rituximab?
No, sir. She was totally compliant.
Person who has already on maintenance of
Yes, sir.
rituximab and uh, effect is negative, then how are you going to diagnose that particular symptom? Chest symptom is it's because of relapse or because of infection?
Sir, first we have to rule out the markers of infection, and from starting from this, TLCs, the procalcitonin levels, the cultures. First, we have to rule out the infection, sir, and then we also look at the ESR and CRP to see the disease, which are indirect markers of disease activities.
ESR, very non-specific. It can be raised in hundred of things. Do you do ESR to decide whether disease is active? ESR is
It,
CRP would be raised in infection as well as in any disease activity. CRP is a marker of the inflammation. How do you diagnose a relapse or infection just by CRP? If the patient,
uh,
no, if somebody has some
supportive evidence, and not diagnostic, but
hemoptysis, no,
yes,
I don't. It is mentioned anywhere that you diagnose this thing by CRP or yeah, I'm not aware. Sagar, are you aware of such thing? I don't know.
No, sir. Like you mentioned, ESR would be very non-specific. While we've said this anchor titers are not correlating. A non-specific test like ESR CRP is not going to help you differentiate purely, like sir asked, infection versus a vasculitis relapse.
No, so that is why I am asking if this patient did not discontinue rituximab, how you were able to reach a conclusion that this patient had vasculitis relapse rather than an infection?
so,
Relapse
all
on
the markers of infection were negative, so when she was evaluated. So
markers of infection of this is malab, that may be possible you might have given antibiotic and together you have also given these steroids, isn't it?
yes, sir.
And you empirically immunosuppress this patient more and more, probably which she did not require. How common is the relapse if the patient is already on maintenance rituximab? Is there any data or is there any study which you are aware of? Usually the relapse occur when you stop the immunosuppression,
Yes, sir.
isn't it?
Yes, sir.
So there is a trial that compared rituximab with azathioprine as a maintenance therapy, rituximab superior, or you stop the maintenance, and then there is a possibility of relapse.
Yes, sir.
If the patient is already on rituximab, then I don't know. I am not aware. Means how common these patients should be would relapse. Any experience, Sagar?
I don't know the numbers, but I think the dosing he was recommended was the same as the main Ritson study, sir.
Yes, sir.
The one that came out in 2014, I think, Ritux versus AZA, because that used the same protocol, 500 mg, two doses, and then 6, 12, and 18 months, because you mentioned the same scheme.
Hmm.
I think it would still be, sir, to the tune of 20-30%, if I had to guess. I'll look it up also today.
I don't remember the exact this data about the relapse, but the so this was superior to azathioprine. One thing was sure. What was exact relapse in these trials that I don't remember. Certain. So I'm just worried whether this was a basically relapse or you just treated some infection with antibiotic and top up that you gave additional immunosuppression. Isn't it? Is there a possibility?
So maybe, sir. We did not have any evidences.
No. So because the marker which you are telling are very non-specific,
Yes, sir.
and so I tell you that relapse on the rituximab was 5% in the rituximab group
Yes,
and
sir.
20% in the azathioprine group. Very uncommon.
Mhm.
So it's not a common thing. have relapse on the patients who are already receiving maintenance immunosuppression with this thing. Is it possible? But
What was the creatinine on this presentation, Dr. Devran?
So in this presentation, sir, creatinine was 0.8, sir, 0.8 milligram per deci.
And what was the urine sediment, the urine routine showing?
Sir, no active sediment, sir. And
So I think Dr. Sham is he's raised a very good point there that, your kidney numbers are normal, your sediment is inactive, you don't really have a strong marker. And then again, even I looked it up, the main Ritson prolapse, it was just 5% with Ritux. So, like again, we really have to have some strong evidence to immunosuppress somebody more who's already received such doses of immunosuppression.
no, what is the clinical evidence of this thing, this patient relapse?
sir, she had, sir, as a new symptom, she had some arthralgia, sir. This was
Arthritis.
only there. Yes, sir, arthralgia, maybe an extrarenal manifestation, which is not there previously, sir. It was, she presented this time with arthralgia.
So you can just give SCQS for arthritis.
Yeah, not a strong enough reason to give rituximab for arthralgia.
Chalo, that's a separate thing. So so how long you are planning to give treatment to this patient now? This is more than 4 years. I think 4 years. So November 2018, your story started.
Yes.
So well, how long will you plan to give immunosuppression to this patient? What is the recommendation? How long one should give maintenance in vasculitis? In PNCA or CNCA, GP or NPA? How long you should continue maintenance?
So mainly, sir, three studies, sir. They gave rituximab, sir, for 4 extra doses at 6 monthly intervals, sir. So, and they followed up and they found that relapse rate was lower.
If you were using azathioprine for your maintenance, like what sir is
Azathioprine, sir,
asking is how long is your duration of
for
maintenance immunosuppression?
for 4 years after the diagnosis, up to 2 years, we give around 2 milligram per kg, and then we start tapering, sir, for at least 4 years, sir, after the diagnosis.
Which study demonstrated the higher efficacy of 4 years versus 2 years regimen?
Sorry,
This was the REMAIN study in 2017.
remains study, yes, sir. Yes, remains study.
I think no discussion on ANCA vasculitis can be complete without talking about plasma exchange.
Yes, sir.
What do you think? What is the data and what are you going to do for your patient?
Sir, there were two landmark trials of the MEPEX and PEXIVAS. So MEPEX showed that there was no difference in all-cause mortality. However, there was dialysis independence at 1 year, sir, in patients with severe glomerulonephritis. And in PEXIVAS, again, they showed that there was no difference between the plasma plex versus no plex group with regards to all-cause mortality. So at present, the KDIGO guidelines suggest that plasma exchange can be tried in case of severe glomerulonephritis with creatinine of more than 5.7 and or alveolar hemorrhage with hypoxemia. So in these patients, we can try plasma exchange.
So like you said, the MEPEX study in 2007, that showed reduction in risk of progression to ESRD.
Yes, sir.
But actually, when they did more data analysis, later they found out that the difference kind of narrowed down and disappeared after 12 months.
12 months,
for
yes.
ESRD and mortality.
Yes.
So the 90s, when there was not much available, and at that time it was more like anecdotal and case series experience when they were doing plex for every ANCA patient.
Yes, sir.
And then the MEPEX study kind of reinforced it a bit. But Pexivas, the recent study, that is the most like kind of, well designed. It was a 2 by 2, plex versus no
Yes, sir.
plex and low dose versus high dose steroid.
Yes,
And
sir.
that is one of the first studies that actually shows that plex may or may not benefit. Like you mentioned, the criteria according to KDIGO, that if your, creatinine is more than 5.7 or alveolar bleed with hypoxia,
Yes, sir.
you can consider doing plex. But
Yes.
as previously thought for ANCA-associated vasculitis that you have to plex everyone,
Yes.
that is what was changed. So this was kind of a landmark trial, the PEXIVAS,
Yes.
that came out in 2020, I think, or 19. So that is
2009.
like a landmark trial of plex versus no plex. And same goes with steroid use.
Yes, sir.
You were
So
talking about, sorry, yes.
Plexivas is a negative trial. No? For plasmapheresis, is there any, maybe some subgroup analysis might have shown some benefit, but otherwise the long-term, the long-term outcome is also out now in Plexivas trial. And there was no difference
No
in plasma
difference.
versus no plasmapheresis group,
Yes, sir.
isn't it?
Yes, sir.
So unless you have alveolar hemorrhage or something
Yes,
for
sir.
renal failure, for patient dialysis dependent, is there any benefit of doing plasmapheresis?
No, sir.
Is
No.
is so this is essentially a negative study.
Yes, sir.
When you were talking about induction, you mentioned cyclophosphamide.
Yes, sir.
How do you dose or how do you do cyclophosphamide dosing in such patients, route and dose?
Sir, we can go for IV or oral, either of the route. In IV, sir, we dose 15 milligram per kg body weight, which is adjusted for the age, renal function, and the leukocyte count. And it is given at weeks 0, 2, and 4. That is at 2 weekly intervals for 6 weeks, followed by 3 week intervals, sir.
Mm-hmm.
And can be
So,
given up to week 24. Yes, sir.
okay. Any difference between the outcomes of oral or IV cyclophosphamide?
Yes, sir. The oral group, because they have higher cumulative dose, so and there is more chance of leukopenia and mortality. But overall, the remission rates, the time to remission, and the percentage of remission rates, these are comparable in both the groups, sir.
What is the
Right.
difference? Any difference in the outcome? Relapse. What about relapse rate?
Relapse rate, these are higher in the IV groups, sir.
Relapse rate is higher in the IV group. Or you will give the dose of cyclophosphamide same dose to everybody, even with patient who comes with a creatinine of 6.
No, sir. If the GFR is less than 30, then we have to reduce by 2.5 milligram per kg, sir.
25%, 2.5
25%. 25%. Yes, sir.
the dose of the cyclophosphamide at least. Okay,
Why do you worry about the cumulative dose of cyclophosphamide?
Sir, because with increasing doses, we can have certain side effects, sir, like above 10 grams, sir, cumulative dose, there is risk of infertility in form of amenorrhea. Sorry, sir.
No, continue.
So in the form of infertility like amenorrhea or azoospermia, and above 36 gram, there is increase in the risk of malignancies.
Yes. So, like for young patients, if you're using cyclophosphamide for any other reason, in today's age, you should offer them sperm banking and ova banking. Many
Yes.
places are offering these services, and the patient has a right to choose this, even if you're doing cyclophosphamide, because, like you mentioned, it severely affects the fertility, and then above 36 to 38 grams, like malignancies,
Malignancy.
bladder malignancy, hematological malignancies, they
Yes.
kind of rise up. So that is why you worry about the cumulative dosing.
Yes, sir.
Any other agent or any other combination that can be tried?
So you can try both rituximab and cyclophosphamide, sir.
Which study used this protocol?
Sir, Ritux was Ritux.
Yes. So in
Ritux was.
rituximab,
Ritux.
cyclophosphamide, was given, like 2 doses were given along
Yes,
with
sir.
the rituximab.
Rituximab,
So
yes.
a combination of the two can also be considered.
Yes, sir.
What are the side effects of rituximab, or what do you need to keep in mind? What do you need to check before giving rituximab to any patient?
Sir, ideally you should check the baseline immunoglobulin level, sir, and the hepatitis B status. Uh, these two are which have been mentioned in KDO, sir. The baseline immunoglobulin and hepatitis
Yes,
surface.
so it can cause a hepatitis flare, it can cause a tuberculosis flare.
Yes.
There are rare causes of, JC virus encephalopathy with rituximab,
Yes, sir.
and then, like you mentioned. So I think that is pretty much. And then when you're transplanting these patients, you have to make sure, the disease is kind of quiescent for, at least a good 6 months.
6 months. Yes, sir.
Sometimes you're not able to achieve a negative ANCA value in such patients, or if you're transplanting, an anti-GBM patient also.
Yes, sir.
But again, you should make sure they're at least the disease is quiet for over 6 months. Any other questions from your side, Dr. Sham? All right, I think we maybe lost Dr. Sham. So this was a pretty good discussion. Thank you, Dr. Devaran. And
Thank
then
you, sir.
again, these diseases are not that common. You're not going to see and, be flexing and inducing these patients left and right in your practice.
Yes,
So a lot comes with your personal experience. Where are you practicing? The social profile of the patient. Like never copy the Western data and just kind of extrapolate it to your patients. Just, a small word of advice in the sense, our Indian patients, sometimes the risk of infection is a lot higher in the subcontinent.
yes, sir.
And then don't forget the individual patient factors. What is their background? What, how malnourished they may be, which all might contribute to, further suppression of the immune system. So always, keep reevaluating your strategies. It's
Yes,
not necessary that you have to copy what is written in the book or what was designed in, a study in US, UK, and keep doing that. So
yes, sir.
not just for this, any other GN or any other vasculitis you're treating, make sure you keep evaluating, and the remember the cardinal rule: first do no harm. So
Yes, sir.
again, see, worst case scenario, your patient is gonna land into ESRD. While you're trying to save the kidney, you gotta make sure you save the patient first, right?
Yes.
So those are the kind of things you keep in mind. But I think overall, again, ANCA is always an interesting topic, and
Yes.
it's very interesting to deal with also in clinical practice. All right. Any other questions from any other students, or I guess we can call it a close. Okay. Thank you, everyone. Have a good day.
Thank you so much, sir. Thank you.
Thank you. Yeah.
Thank you, sir.